Hi everyone, my name is Kevin Schuster of Naples Personal Training. I'm here today with Dr. Otto Jaasko, and we're going to talk about pain. And so, Otto, tell the audience a little bit about yourself and what you do here at Naples Personal Training and your background for them to know who you are.
Hi everyone, my name is Dr. Otto Jaasko. I am a doctor of physical therapy as well as a sports medicine provider here at Naples Personal Training, and I provide kind of a well-rounded realm of different services from rehabilitation all the way down to performance training, and I've had experience working with a variety of patient populations from chronic pain to professional athletes. So.
Great, so today we're going to talk about understanding pain, is that correct?
Correct.
Great, so tell us a little bit about pain and how it works, why we experience it, and why some of the experiences it differently than others, and the connection to injury that pain has.
So the physiology of pain is relatively complex when you think about it from the neurophysiology aspect, but ultimately it comes down to a perception that's made in the brain. So it is a cognition. Your brain has to recognize something is wrong and then provide an output that is what we feel as pain. So this is a concept that we see in individuals who have had an amputation, and when they experience phantom limb pain, these individuals don't have the limb anymore, but they still perceive pain in the phantom limb. And this is something that shows us the aspect of the cognition that the brain outputs as the pain response. So essentially, when we have an injury, for example, we do get obviously pain receptors that get activated and provide information into the spinal cord, and then from here, from the spinal cord into the cortex of the brain. But it's not the receptors that create the sensation of pain. It's the brain that actually outputs it. So when you think about this in the context of in different individuals experiencing pain differently, we see that there is pretty much a bell curve of spread when we think about pain pressure threshold. So the bulk of the individuals fall towards the median, meaning that most people are kind of scattered in this, or kind of focused in this central area where a moderate amount of pressure finally creates a painful response, whereas then we have outliers that some people, the smaller portion of people, get the pain response almost, kind of immediately with pressure that shouldn't be painful, whereas then we have the opposite side of the outliers who require an intense amount of pressure to actually feel that pain response. So then we start looking at why this difference exists, and we've kind of now started theorizing and also supported by research that the neural matrix, which is the kind of the physiological interconnection between different areas of the brain, together with the spinal cord and the receptors, kind of form differently between people based on experiences and memories and so forth. So that explains the difference in the pain response, and also the intensity and the threshold when it comes to different individuals. So and then when we look at this in the context of injury, we see that, for example, with low back pain or non-specific shoulder pain, we see that when we look at symptomatic individuals, who are in pain, and asymptomatic individuals of the same, adjusted age and so forth, we see that the actual, imaging-related damage or pathology is very similar in these groups. So, with that being said, we can't really tie a pathology often into pain when it comes to atraumatic pain syndromes, and with that being said, again, you can have two individuals, one that is in pain, one that is not in pain, and then when we actually look at an MRI of their spine or an MRI of their neck or their shoulder, they might have exactly the same type of condition of their structure, but then one is in significant pain and the other one, has maybe never had pain in that area. So,
and so a lot of it has to do with the experiences they've obviously had in the past.
Right.
With the pain then.
Right. Yeah. So they do see, in research they do find that there's a pretty significant association between, different memory areas of the brain and, areas that kind of coordinate the memory transfer from experience to experience and so forth. Between the different cortexes. So the memories definitely play a significant role in how you form pain response throughout your life and how it gets modified.
And so that could be one of the things why people get re-aggravated injuries or re-aggravated pain is because of the memory.
Right, and it is in many pain syndromes. We do find that once you have the injury or the pain once, you're more likely to have recurrence. So that's why it's important that different pain syndromes get managed appropriately and not catastrophized, but rather kind of considered in the context of that it is somewhat normal to have pain syndromes throughout the life. Just we want to try to minimize the impact that it has in your life.
And what are some of the common musculoskeletal pain syndromes?
So when it comes to the musculoskeletal system specifically, again, this is kind of weird to talk about in just the context of the musculoskeletal system because the neurophysiology of pain is so important. So you could almost argue that it's more of a nervous system related issue. But when we look at it from the traditional context of musculoskeletal pain, some of the more common commonly seen issues are obviously low back pain. We see that more than 90% of people experience low back pain in their lifespan. And then we have, non-specific shoulder pain, that is, atraumatic, meaning that there hasn't been a significant trauma associated to an onset of pain. Same thing with neck pain, knee pain, and hip pain. Those are all kind of, fall into a similar type of category of non-specific pain, although low back pain is kind of now taking that the bulk of the attention in terms of looking at non-specific pains, meaning that we're not after a specific structure that we want to identify that's a causative factor for the pain. But now more and more research is starting to push the envelope on not necessarily needing to find a particular structure that is so-called injured, but rather treating the pain as a syndrome rather than a structure.
Okay. And so what are some of the challenges that overmedicalization brings to the average person in pain?
Right. So overmedicalization is refers to the excessive use of different diagnostics and medical procedures. So overuse of X-rays and MRIs, medications, surgeries, such as orthoscopies or even injections. And when we think about a lot of non-specific pain syndromes or atraumatic pain syndromes, like we talked about the low back pain and shoulder pain and all that, there's really no reason to, in most cases, really no reason to identify a pathology in the structural system. Although the evidence suggests that the patients want a specific diagnosis, so it's important to patients they get a specific diagnosis on what the structure is that is involved. But then we also see, on the other hand, from clinical research, is that when the patient knows or a specific pathology is identified, such as with MRIs of the low back, we see that the outcomes of treatments, kind of plummet. So it's kind of patients want to know what's wrong with them, but then at the same time, over-medicalization brings this kind of a negative connotation and this, rainy cloud on the whole process of rehabilitation and getting better. And we see that it's not really, good for the prognosis, or it's not really, a most appropriate use of our time and resources.
So that person that is in pain, what should he or she do to approach the pain?
So obviously pain is to most people it's a pretty significant experience. that is most often in a negative experience, and especially with people that have been in pain for a long time, they can be debilitating. But if there is no significant trauma, meaning that there hasn't been a car accident or a fall down the stairs, anything like this, most of the time the injury is not, in an emergency. So, getting to the medical procedures right away is probably not the best way to go, especially when it comes to these musculoskeletal conditions. So, I think the best thing would be that patients and individuals would be able to kind of manage their pain and not catastrophize it. So not give it too much of the too much cognitive reinforcement of the negative, right? So not kind of making it the top priority, but it's understandable that it is difficult to do when you're in pain, right? So that's where really rehabilitation professionals come into play, like physical therapists, where we're trained to assess the neuromuscular system and the musculoskeletal system, and provide education on the pain science and provide movement that is pain-free, and with that reduce the catastrophization and improve self-efficacy, where the patients are able to now kind of be have ownership over their pain, and get better without the medical procedures that we see are associated to reduced outcomes and poor prognosis.
So typically people in pain need to have a X-ray or MRI?
In most cases, no. Again, this is something that is contextual to some extent. So, if you, for example, I'll give you an example that kind of, can go both ways. Let's say you, misstep a stair or a stair step going down and you twist your ankle. You most likely, it's been a sprain of some ligaments, or tendons, strain of tendons, things like that. But there's a chance that there's a fracture. Now, when let's say you would go see a physical therapist first. The physical therapists are trained to screen out medical emergencies, and significant trauma like fractures really well. So what we have is, what's called out of my ankle rules, where, it's a battery of tests, and, if the person is able to perform all of those tests without issues, then, it's, over 99% likely that there is no fracture. So in that case, the rehab can start right away, and therefore, the outcomes and the prognosis and the timeline is significantly different than if you were to go directly to the ER, and just get an X-ray and medications and a boot, and then we're left home and sent home without anything else to do. That obviously significantly pushes on the timeline and makes it longer, and probably decreases the prognosis, especially in the short term. So again, there it's a musculoskeletal issue that's traumatic, and even there, physical therapy can help either screen the pathology out, and therefore can start the rehab process, or refer you out for a concern that maybe there is a fracture, and at that point it's appropriate to get the X-ray. But again, that's the job of the doctor of physical therapy to go through that screening process.
And so that brings us to, how can a physical therapist help, and when is the appropriate time to get a PT evaluation? So
again, the first thing is physical therapists screen out. So we go through the medical screening, and make sure that there's no pathology there that requires or warrants a medical referral. And in most cases of especially atraumatic injuries, there's no need for a medical referral. And then from there, the physical therapist will create a tailored approach to the rehabilitation of whatever the concern is. And with doctors of physical therapy, being highly educated, there's we understand the importance of involving the patient in that tailored approach, and making sure that there's good self-efficacy for the patient to kind of have the ownership over the issue. And here at Naples Personal Training, we also provide kind of nutritional education and education on stress management and sleep, which are all important things, especially when it comes to recurrent pain syndromes. And that really is what kind of separates good physical therapists and rehab and exercise professionals from the rest, is the understanding of the whole person. And then when it comes down to kind of what's next, after you've gone through this traditional physical therapy treatment plan of care, is now you have to kind of not just stop, but try to prevent it from happening in the future, and allow for better quality of life, than what you had during the injury, but also before the injury. So here at Naples Personal Training, we really focus on the transition period, and we provide the doctors as personal training programs where you kind of continue on a combination of what the rehabilitation needs, but also what the training would be in the most appropriate form. And then obviously the nutritional services and the recovery and sleep, as well as just health coaching that we provide, makes the big difference between just doing the rehab and then being done with it, and then 3 months later having the issue flare up again.
And so talk about some of the advantages here at Naples Personal Training that physical therapy client would have compared to a traditional physical therapy location.
Right, so the first thing is, we provide cash-based physical therapy services, which do not require a physician referral, so you have access to physical therapy, first as a direct access, and that can significantly reduce the cost, first of all, but also reduce the timeline on how quickly you recover, and also improve outcomes. That's the first thing. The second thing is that our physical therapy treatments are very highly tailored, meaning that not everybody with the same condition, or everybody with low back pain gets the same treatment, because we're extremely evidence-based in our approach, and we have our doctors of physical therapy are very well educated and well rounded, with different specialties, and not just the generalist physical therapist that you might see at some other places. So with that being said, the quality of care is also much better than what you would see at traditional physical therapy centers. And then on top of that, you add the transitional rehab into personal training.
And talk a little bit more about the ADAPT program, or the transitional program, so that the viewers know exactly what we're talking about.
Right, so the ADAPT program, the Doctor Assessed Personal Training program, it entails a initial examination by a physical therapist, to determine what the level of the individual is, but also precautions, things like that, and the most appropriate exercise approach to that person. And then from there, the individual would work with a personal trainer or exercise specialist under the umbrella of the doctor of physical therapy, who would kind of oversee the program and coordinate well with the fitness professional, exercise professional. And then as needed, there are kind of reevaluations, if you will, with the doctor of physical therapy to determine the effectiveness of the program, and kind of update the program as needed, as the person continues to improve and get better.
Okay. And so if one of our audience members wanted to get physical therapy from Naples Personal Training, what would their first step be?
So they would contact us and contact Kevin And then, you know, the person will talk to a wellness specialist, me or Nick. And then, you know, from there, you know, let's say we talked, we would determine the best, you know, approach to the rehabilitation, depending on what the specialties of the doctors of physical therapy here are, and also what the complaints are. And then from there, we schedule an assessment, an evaluation, and, you know, that's where really we determine whether the doctor-assessed personal training program is what you need, or you know, a short bout of physical therapy with the doctor of physical therapy.
Okay. And so if there's one key point to get from understanding pain, what is the most important thing you want our audience members to learn from this?
So I think the most important thing is that that the pain does not, you know, it does not mean that there is something structurally wrong. The body is very robust, and, you know, tissue quality does not, you know, correlate to pain. So typically the more important approach to pain is to think about the pain as a sensitivity meter, and with appropriate movement and appropriate, you know, cognitive, you know, approaches, you know, like decreasing catastrophizing, you know, decreasing the fearfulness, improving self-efficacy, things like that, are the most valuable things you can do to reduce the sensitivity, and, you know, that way get back to good quality of life, and, you know, strengthening and maintaining that good quality of life, you know, when you're in these pain-free stages of life. And the other thing that it might be even more important is that, you know, having pains is to some extent normal. Most people, you know, over 90% of people experience pain in their life, and so we just need to make sure that that pain is not debilitating for a large portion of the life, obviously.
Very good. Well, I want to thank Dr. Otto for joining us today. And if anyone is interested in doing any physical therapy or personal training with us, you can call 239-597-2370 or email kevin@naplespersonaltraining.com. And thank you, Dr. Otto, for helping us understand more about pain. If you have any questions, once again, give us a call at 239-597-2370. Thanks.